with the idea that if you change your thoughts and behaviors, it'll change your mood or your anxiety. And they've done it now. They've shown it to be effective even in schizophrenia.
Yeah, but combined with medication for some.
For anxiety, it is the treatment of choice. Yeah, if you have panic disorder, social phobia, generalized anxiety disorder, post-traumatic stress disorder, cognitive behavioral therapy with medication is the treatment of choice. I mean, hands down. The medication works in the short run, and the cognitive behavioral therapy works in the long run, and people that do the cognitive behavioral therapy and stick with it, they stay better longer than people that just do medicine alone. Cognitive behavioral therapy then, so let me think of a good example. Let's use depression, I guess, it's the first thing that came to mind. So depression, what happens when you're depressed? Is anybody, you get really negative. And so the thoughts you have are very negative. It's things like, geez, I can't do anything right. Everybody hates me. Nobody cares about me. These are called automatic negative thoughts. Okay, in cognitive behavioral therapy, they call them automatic negative thoughts. They pop into your head. You probably don't even realize you have them, but you are having them. In cognitive behavioral therapy, they would challenge you. The therapist would sit down with you and say, I want you to keep a thought record. And a thought record would be, usually with the first thing you notice typically is not the thought, but it's some feeling. You all of a sudden get very depressed. Then, so what it'll say is, okay, emotion on one side. It'll have mood. You'll say depressed. And it'll have your rating. Out of 10, it's 10. It's the worst that it can be. The next thing is, what's the thought that went with it? And sometimes that's hard for patients, but eventually they come up to, or sometimes, they'll have a situation. What was the situation that happened? And then what was the thought that you had about that situation? So maybe the person has, let's think of an example of something that might happen to somebody. They go through a checkout in a supermarket, let's say. The person treats them very rudely, okay? So they come out of that checkout, well, even that person who doesn't even know me thinks I'm worthless. And that's the thought, I'm worthless, based on the situation of that checkout lady treating me bad. So the psychotherapist would then ask the patient, I want you to challenge that for a second. I want you to stop and think rationally about that. Is it likely that that person even knows you from Adam? And they really challenge them to think about what's the likelihood that these things are true, that you're thinking, that you really are worthless. And they would do things like, so even if the cashier thought you were worthless, who is the cashier? Is she God? Is she ultimate judge of you? What do your parents think? What does your spouse think? What do your kids think? They all think you're worthless? And typically the person's like, well, okay, they say they don't, and all these things. And then by the end, after you have them go through this process of thinking through all these steps, at the end you have them rate their mood again. And invariably, it usually drops down. It's usually a little better than it was. And you do the same kind of thing with anxiety. There's different types of, let's say with OCD, obsessive compulsive disorder. You do a type of cognitive behavioral therapy. It's called exposure and response prevention. So if they're fearful of contamination with germs, you have them go in and you work up to, you don't usually have them just go right and do it, but have them work up to touching a toilet seat or a toilet rim, okay? And because let's say their obsession is, of course, the germs, and they don't want to touch anything, let alone a toilet seat. They wouldn't even touch a door handle or the chair or anything. So usually the thing that they would do is they would wash their hands compulsively over and over and over again after they touched something they thought was dirty. And the idea is then you work them up to touching something dirty, but don't let them wash their hands. What happens is you expose them to what they're so afraid of and force them to see that they didn't die, that nothing bad happened, despite not washing their hands. That's another type of cognitive behavioral therapy, and it's extremely effective. But people don't like to do it. Why? Because, well, first of all, it's hard to find people the therapists that'll do it with you, but it's also hard because people don't want to do something that takes a lot of work, right? Well, it's much easier to take a pill if you can take a pill. But the pills work fine, but they're not near, if you do both things, it's the best. As you can imagine, right? If you behaviorally expose yourself to something over and over again and you see that nothing bad is going to happen, it's like fear of flying, it's like any fear. If you expose yourself over and over again to it, eventually the fear goes away because nothing bad happens. No longer are you afraid of what might happen because you've done it and nothing happened. So, going forward in the long run is the best. It's really good treatment, but it's again difficult to find. So does that answer the question? That's a long answer, wasn't it? So that's just actually one type of psychotherapy. It tends to be a really well-studied type. I mean, they've studied it in all different types of illnesses, and it's been very effective. So, okay. So the next question I have is are all psychiatrists like Freud, practicing psychoanalysis and having you lie down while they analyze you? And obviously, like I said, that's unusual. It's not done much anymore. There are certainly psychoanalysts out there that still treat folks. Personally, I think anytime you stick with one particular type of treatment and you try to fit that to every single patient, that's probably naive. That's probably not going to work. So I think the best psychotherapists actually are flexible enough to know when CBT is going to work for someone versus psychoanalysis versus different types of psychotherapy. Okay, so there are still some folks that do psychoanalysis, but not as much. And in the old days, you'd go to see a psychiatrist, and they would do everything. They would do the psychotherapy and the medication. And personally, I think that I sort of wish that still was the case, because who better to do your medicines than somebody that knows everything about you, that knows the core you. If the psychiatrist, if all the psychiatrist has is 10 or 15 minutes to see you and ask, are you having side effects from your medicine? Okay, let's refill this. I mean, that's not enough, And I'm going to give you a real world example here in a second, but the reason it's kind of gone this way is, the third-party payers, the insurance companies, Medicare, Medicaid. Obviously, they're in it to try to save money. They want to save money, so they want to pay the least for a service that they can. So if you'll notice, what's happening is you don't see them paying physicians as much. They'll pay physicians sometimes, but a lot of times you'll have nurse practitioners, clinical nurse specialists, and now doing psychotherapy, you have social workers. You're not even psychologists, but social workers now doing psychotherapy. These people sometimes are excellent at what they do, so I'm not taking away from what they do. They're well trained and they're very good at what they do, and I worked with a lot of them where I was. But I just think that the biggest piece that's missing is the coordination, especially if you're not in the same clinic. If I'm seeing somebody for medicines and a therapist across town is seeing them, realistically, how often I'm not going to be able to call them all the time and run the patient by them and see how it's going. Usually it's only going to happen if something bad is happening or something's going wrong. But I think, getting away, that's called a split treatment model is what that's called, where this treatment is split between two people. And it's not always the best thing. Think about it with regular medicine, right? How hard is it for your family doctor to keep track of all the specialists that you see? That's difficult. They do the best they can, but it's difficult to do that. What did Dr. X start you on yesterday? And what labs did Dr. Y do on you last week? And that's difficult to keep up with, especially in this day and age. Eventually, maybe things will be on the internet, and you'll be able to type in your Mrs. Smith, and boom, all of the labs and all the meds and everything is all in one system that all doctors can access. But at this point, we're not there. So, with this split treatment model, I sometimes fear, and I see this. I'll see patients referred to me that have seen a whole bunch of psychiatrists. They've tried a lot of different medicines, and nothing seems to be working. And they'll come to me with treatment-resistant something, treatment-resistant depression, treatment-resistant bipolar disorder, whatever it may be, anxiety. And invariably, what ends up happening is that the psychiatrist hasn't really had the time to spend with that person and really get to know what's going on. And so, let me give you kind of an idea about that. And when I was in practice, part of the reason I left practice is because they were pushing us to go into the 10 or 15 minute med check model. At the time I was doing 30 minutes, and sometimes it'd take me even longer. I had 45 minutes or so on a follow-up appointment. Okay, I tend to like to hear all about what's going on with the patient before I make decisions on medicine. And once I make a decision on medicine, I want to tell the patient exactly what to expect with the medicine. And the illness, what to expect of the illness, and how are they going to improve. If you don't set the person up for success, you're not going to have success. So if you don't explain, hey, this is an antidepressant, it ain't going to work overnight. You're going to get a call 2 days later saying, Doc, you started me this 2 days ago, it ain't working. I'm going to say, I should have told you probably, but I didn't. It takes 10 to 12 weeks to work. What? 10 to 12 weeks, I can't wait. So you have to have that conversation at the very beginning. And you don't have that luxury sometimes in 15 minutes. So I'm preaching a little bit. Let me stop. Let me tell you about a real world situation. A little a patient that I see him. I have a volunteer clinic, and so because it's a volunteer clinic, I don't get paid anyway. So I can spend as much time as I want with the patient. Okay, and well, wait, you're looking funny. What's that? It's a volunteer clinic.
I'd like to be your patient.
Well, it's
I'd like somebody to have a lot of time.
it's something that where I work, they allow me to do that. It's a half day a week, and basically, this person came in, and an elderly woman came in with her family, and I met with the family and the patient in the very beginning, and the story was that she had treatment-resistant depression. So she had major depression that had not responded, according to them, to many, many different treatments and different psychiatrists. They'd seen several different psychiatrists. So when she came to me, I took tried to take as good a history as I could, and I think it's probably spent 2 hours with them the first time I saw them, and the best history I could. And from what I could tell, symptom-wise, she really had partially responded to what she just had been started on about 4 weeks ago. So I said, well, let's take this medicine and let's increase it a little bit, and let's give it another 4 weeks. I explained to them what to expect. That you're not going to notice a difference probably in 4 weeks, a lot of difference anyway. The family might, but you won't. Sure enough, 4 weeks later, this medicine's not doing anything for me, doctor. I can't tell a bit of difference. The family says, I think she's getting a little better. She's starting to come out of the room a little more and go out of the house a little more, starting to do her housework like she used to do more. Starting to get back to her old self. Not exactly there yet. And she had complained from the very beginning of a pressure in her head. And I tried to narrow it down or nail it down with her. It wasn't a headache, she said. It wasn't really painful, just the pressure. I mean, that's all she could explain. And she'd been checked, for brain tumors and different things, and nobody could find anything. And she still was real tearful, especially in the morning, and depressed, in the mornings. And then as the day went on, she'd feel a little bit better. So after that first 4 weeks, she said, no, I'm no better at all. The family said, she's a little bit better. I said, let's just give it some more time. Let's not tweak the medicine. She, of course, wanted to change the medicine and try something different. It's tough sometimes to say to somebody, no, you got to wait, but we waited another 4 weeks. Sure enough, she was a lot better. And she even felt better, although she still said, Doc, for about a half an hour every morning, I'm still kind of down. I cry a little bit, and I have this pressure in my head. I think we should try something different. Again, I resisted, and this time I said, I'm thinking that we're about as good as we can get with the medicine. This is probably about all we can do, and you've tried about everything else, so I don't know what else to try. So I said, let me see you back next time for an hour, just you and me, and let's talk. And sure enough, as we did this a couple times for an hour, and sure enough, it came out that she's always been what I call a stuffer. Never really before we can get to that, she has a whole bunch of guilt built up over the years about different things. Okay, one of the things that she was so guilty about, probably the biggest thing was, and I think it was some anger towards her husband too, that 3 years ago her mother had needed nursing home care, and it wasn't 3 years ago, it must have been longer than that. I can't remember, because she's in her 80s, so mom must have been, maybe it was 3 years, I don't know. But her husband said, no, you can't bring mom into the house. And she was saying, well, I promised mom I'd never put her in a nursing home. She had to put mom in a nursing home. And I don't blame the husband, because I think she was depressed. The patient was depressed. She probably couldn't have taken care of mom at home. So puts her in a nursing home. Of course, mom eventually passes away 3 years after that, and she still, I swear she said it was 3 years. But anyway, for this whole time, she's never talked about that with anybody. And she had to be angry with her husband about it, I'm sure. She had said no, but I'm assuming she probably had some of that in there. But also just very, very guilty about that, about having to do that to her mother. She never, like I said, doesn't talk to anybody about that. And besides that, she doesn't talk to anybody about anything that upsets her. So if somebody says something that's hurtful, she won't say anything about it. If somebody gets angry, she won't say anything about it. If there's a conflict, she avoids conflict at all costs. She basically takes all of her emotions and stuffs them inside. Grins and bears it, right? And she's from the old school. And that's the way society, I shouldn't say old school, because society still teaches that. It's not okay to cry, it's weakness, when you have to urinate, is it weakness to urinate? No. It's a bodily sensation, a bodily drive, right? if you have an emotion and you feel like crying, cry. Maybe there are some situations where you don't cry. Like, I wouldn't cry in the middle of the office in a big meeting, probably. But maybe go to the bathroom and do it. I don't know. But anyways, she didn't think it was appropriate to cry ever. And, so what would happen is, at least the way I conceptualized it, she would cry for these little periods in the morning, and it would relieve this pressure, and it would relieve her basically her emotions, it let the pressure off, and she'd feel okay the rest of the day until things start to build up again, and by the next morning she was worse again. I tell people it's kind of like a pressure cooker, with a little valve on it. Crying is like your valve, at least one valve. There's a bunch of different valves, but crying is probably one valve. If you clamp that valve down as tight as you can, what if you do that on a pressure cooker? What happens? Right, explodes. So, I told her that, and I said, I think we have two options. It's not going to be medicine that's going to fix this. I think either you do some psychotherapy and you learn about how to kind of stand up for yourself, be a little more assertive, get your emotions out, and not be so afraid of conflict and afraid of hurting someone or anything else. Get stuff out little by little, and then it won't build up on you. Or just be okay with the crying a little bit in the morning. A half an hour every morning crying a little bit. That's not going to hurt anybody. It's probably safer than tweaking the medicine and adding all kinds of crazy medicines on board when you're 80-some years old. So that's kind of where we stand at this point. I'm going to be curious to see what happens. Whether she, at 80-some years old, I can't expect her really to go into psychotherapy and start doing a lot of work, but we'll see what happens. Maybe she will. So we'll see. But the other psychiatrist, it's not like I'm a super smart guy or anything. I just spent the time with him to sort that out. I mean, the other psychiatrists didn't take the time. They didn't have the time or didn't take the time. In 15 minutes, you can't get to that. First of all, she's not going to open up to you in 15 minutes. It took her probably 2 or 3 sessions of an hour to open up to me. And probably the family went in with her every time, and she couldn't talk about that stuff in front of the family. So I think in an ideal world, it would be nice if there was the luxury of, if the system would reinforce good treatment and not necessarily the cheapest treatment, the cheapest thing. Sometimes you get what you pay for, and I'm afraid sometimes, in psychiatry especially, that may be true. Okay, so that's that example. Any questions about that? Some laughter out there. The final thing I wanted to... Go ahead.
Oh, it wasn't about that specifically, but about the stigma.
Yeah.
I keep thinking of that, but insurance companies, I think, encourage or cultivate that stigma too. As far as life insurance, you take Prozac, and well, you get a high rate then.
Yep.
That kind of thing.
Yeah,
discrimination in some cases.
It is discrimination. It absolutely is, and there's a big push by psychiatrists and other, and NAMI and people support groups and such for folks that have brain illnesses and psychiatric illnesses. The push is that for insurance, there's a thing called parity. Parity just means equality. They for some reason discriminate against covering psychiatric issues. They'll pay $1 million limit on medical problems. $10,000 on psychiatry or psychiatric illness. What is that? Hello? Is the brain somehow separate from the body? I mean, what's the deal here? If it was a stroke, they'd be paying for it. So if it was Parkinson's disease, they'd be paying for it. Parkinson's disease, by the way, is not too unlike a psychiatric illness. It's a chemical imbalance. It's basically some nerve cells that are dying, causing a chemical imbalance in the brain. It's funny, but see, that presents physically. You can see, the symptoms of Parkinson's disease. So maybe we discriminate a little against those folks, but not as near as much as we do against folks where you can't see the issue. I would actually argue that you can't see it, but I think what it is really is that it's such a slow. These things kind of kick in slowly and gradually, and it's if you took a picture of a person who was not depressed, just their face, and then severely depressed, I bet you anybody in this room could tell which one. Diagnose the person without even just like you could diagnose Parkinson's disease, or you would maybe be able to say it's Parkinson's, but you could say, hey, the person's shaking and moving, and they don't want to be moving. There's something wrong. So I guess that's why that's part of the reason. But you're right. The stigma it's pervasive in every aspect, insurance and society, everything. So, one other topic I wanted to cover real quick that I think leads to some stigma is that everybody is fearful that psychiatrists are running around taking people's rights away. okay? Because sometimes we commit patients, right? And I think that, I don't know, maybe people think we're, power hungry. We love that. We would love to run around and, oh, you're going to the hospital now. You said that, you're going to the hospital. First of all, it doesn't work that way. I mean, a psychiatrist doesn't have that power all by themselves. So let me tell you a little bit about how that goes in real life. There are laws in the states, and in most of the states in the country, there are laws that are set up to protect both society from folks that have a psychiatric illness and also the person themselves from themselves, okay? So an example might be somebody who is paranoid that somebody's out to kill a family member, okay? And then they start feeling like, I'm going to go take them out before they take my family out, okay? That person's dangerous, right? Would you all agree? Is that a person you want running around the streets? No. Are they likely to go ahead and get treatment on their own? Not at that point, because they don't see that there's anything wrong. To them, it's very real that this person is trying to take out their family. So the courts basically have set up laws so that a family member of that person can go into a psychiatrist and say, Doc, you got to do something. My mom is really having some issues. I don't know what's going on, but here's what she's doing. The psychiatrist hears it and says, boy, this is dangerous. I'll tell you what, you fill out a paper here, and there's a petition that a family member, a friend, or somebody fills out. The psychiatrist fills out a form, a doctor's form, and then it's sent to a judge, and a judge then signs it or doesn't sign it, but usually signs it, and then that's basically an order then for the police to go out, pick up that person, bring them in for treatment. Bring them in for evaluation, not treatment, evaluation. And that could be 72 hours. It's a 72-hour hold. So as you can see right away, is the psychiatrist doing that all by himself? He's not running around ordering this stuff to happen. No, it takes three things. It takes a person to identify a problem, it takes a psychiatrist, and it takes a judge. So there's three people making the decision. When the 72 hours starts, it counts during business hours of the court. So it doesn't count weekends or holidays. So I think people get, they don't realize that, and they get ticked about that. But what the evaluation period is, it's time for the usually it's in the hospital. The doctor will bring the patient to the hospital and watch the patient on the unit. If the patient is not in any emergency situation, the doctor can't force treatment on the patient at that point. The only time he can is if that person's getting ready to jump out the window or hurt the nurses or hurt another patient or something like that. Then he can give them medicine to calm them down and keep them from hurting somebody. Otherwise, he can't give them treatment. With the exception of the patient, of course, the patient says, "Yeah, okay, I got you. I'll grant you that, doc. I'm having some problems. Let me try something." Then it's more of a voluntary thing. Let's say in the 72 hours, the doctor says, "Yeah, I think this person has schizophrenia and it's out of control," and the person's refusing treatment. And I do think they're dangerous after the 72 hours is up. It wouldn't be good to just let that person go out and go ahead and hurt somebody, right? So he goes to the judge, fills out some more papers, sends them to the judge. The judge says, okay, come in, on such and such a date, we're going to have a court hearing. The patient stays in the hospital until the court hearing. At the court hearing, the patient has an attorney, gets represented. The doctor has an attorney from the hospital usually. And they both present their cases. Sometimes the patient will talk. And the judge makes a decision. Okay, yeah, you're committed to the care of this doctor for up to 90 days. Usually the first time it's up to 90 days. The doctor then can say, okay, you need to stay in the hospital. We need to start you on treatment. At that point, he's got an order to treat the patient. So that's kind of how it works, okay? It doesn't mean they stay in the hospital 90 days, by the way. It means that's sort of up to the doctor. If the patient's better in a week, they go home in a week, but they still have to see the doctor and stay off drugs and alcohol and that kind of thing. So there's a court-ordered treatment. And it's the court that orders, it's not the psychiatrist. So it protects the patients really from a psychiatrist who, if there were a psychiatrist out there who was power hungry and wanted to order all these people around or whatever, I don't know why. It's a lot of hassle. I would never want to do that if it wasn't absolutely necessary. And it actually is very rare for it to happen, but it's a good thing that it's available if needed.
But does the insurance interfere with your treatment like it does medical doctors a lot of times? Like you can only keep this patient in so long.
Absolutely, yeah.
And I think that's a crime too.
Yes. In an everyday situation, let's say it's not an absolute emergency like we just talked about, and that's a good question. When it comes to the absolute emergency, I don't know. I imagine different insurances are different. I think some insurances just have a maximum. They'll pay you. That's it. You're done after that. But I mean, if it's an emergency, the patient stays in the hospital regardless. So the hospital writes it off, or something happens. I don't know. They work out some kind of arrangement. But no, you're right. Let's say it's a situation where the patient is. Well, let's use the same example. This time the person's been ordered to the hospital. They've been there a week. They're starting to get better, but they're not all the way better yet. What insurance companies do is they have what's called diagnostic-related groups, and these are things like if you have schizophrenia, then you get 5 days in the hospital. You know, as if everybody with schizophrenia has exactly the same illness, and it gets better and worse exactly the same times, and every medicine works just exactly the same. I mean, that's ridiculous. It's like saying, if you have a heart, they do the same thing with medical illness, though.
Yeah,
but if you have a heart attack, you get so many days. That's it. And if you want more days, you got to fight to get them.
It has to be terribly frustrating.
Yeah, and it's pretty frustrating because the hospitals usually have people to try to save their rear ends because doctors just do what they want to do. What's right for the patient. So the person would come around and say, "Doc, you need to discharge this patient tomorrow." I just look at them like, okay, well, what are you talking about? And then I never tried to argue much with them, but I'd seen physicians, just get in arguments with them. I had one insurance company tell me on a patient of mine recently, we won't cover this medicine, and the only way we'll cover it is if you take them off of that the medicine you want to put them on, you take them off of that and put them on this medicine, and then they have to fail it, and in other words, get worse. And of course, to fail it takes 8 weeks, 10 weeks, and then they have to fail something else for 8 to 10 weeks, and then we'll cover this medicine. I said, wait a minute. You want me to purposely make my patient worse and let him suffer for 16 to 20 weeks for you to cover the medicine? How would you like if I did that to you? And the lady just, well, you can fax us a form, and that's why I faxed them a form, and they covered it. But that kind of stuff, it gets a little ridiculous sometimes. That's pretty much all I have. I was going to summarize it all by saying, psychiatrists are real doctors. It's a real medical specialty. Why we're not head shrinkers or power hungry people, and we wouldn't go into it. Think about it. Why would you choose to go into a profession where you're stigmatized against your patients and the illnesses are stigmatized by insurance and all these society, religions, all these things? It makes it so hard, And why would you go into that if you really didn't really care and want to help people, So that's what psychiatry is all about, and I love it. Besides the fact that the brain is fascinating, so you learn more and more about the brain as time goes on. So any questions about that?
Yeah. What's your opinion of those OTC meds like melatonin and some of those, or even herbal things? I know medical doctors normally don't prescribe or encourage herbal things because there's no FDA.
Right. There's two things. Sometimes there's not very good studies about it. So there's not a lot of data to guide the doctors on what, or the patients, on how much do you take, how well does it work, and what does it work for. But also, FDA doesn't regulate how much is in, like if you went to Walmart and bought St. John's wort, it'll say on there how much is supposed to be in each capsule. That's not regulated by anybody. FDA doesn't take samples off the shelf, test it, and say, yeah, okay, it meets the requirements. It's within this range of that amount, like they do with prescriptions. That doesn't mean they don't work. It just means it might be variable. So even if it was something that worked, it might work. You might be taking a certain amount, and then boom, you get a bad batch, and you wouldn't know that. You just might get worse, and wouldn't have any idea why. There is some evidence. Having said that, there is some evidence that some of the I shouldn't just say herbal, but alternative. Let's just use that word. Alternative medications or treatments might work. Some of the ones that we think, like for depression, there's a treatment called SAMe, and it's a great big long chemical name that I couldn't pronounce. S-adenyl methionine or something like that. The only problem is that it's just as expensive as prescription. If you have to use quite a bit of it, and I've priced it like at Sam's Club, just curiosity to see how much it was. When you add up how many capsules you have to take, it ends up being just as much as Prozac or Zoloft or one of those every month. so it in a couple of studies it's been equally effective to prescription antidepressants. Fish oil, there's some interesting data about fish oil. It's still a little bit up in the air, but for bipolar depression, fish oil, there was a study using 9,000 milligrams, 9 grams of fish oil that helped their people with bipolar disorder, and they were in a depressed phase. It helped bring them out of the depression without making them manic, which is always the concern, with bipolar disorder. What else? St. John's wort is for mild depression, maybe, but it's not really recommended because it actually can interact with other prescription medicines and sometimes cause severe reactions, hepatic, liver problems and serotonin syndrome and some other things. And so I think in the United States that's kind of fallen out of favor.
Now you mentioned serotonin. Now I understand that melatonin is produced, our body produces that.
Right.
So take more of that.
Melatonin is produced the theory is that this is what we think is happening is when you go to sleep, when it gets dark at night, let me make sure I get this right, the melatonin secretion increases, okay, which then they think is part of your body's kind of your circadian or clock sort of cycle. So you basically start to get sleepy when it gets dark, and then when it starts to get light in the morning, your melatonin level drops and it's supposed to wake you up. And we have a lot of trouble because now we've changed time, so almost all of us get up when it's dark. So we're sort of fighting our bodies a little bit, and that's why it's so hard to get out of bed when it's dark, probably. If you notice, in the summers, when it's 6 a.m. comes and the sun starts, how much easier it is to get up. So, people have studied melatonin for jet lag, for things like trouble falling asleep, and it's been variable. It's not really clear why, but sometimes it works in some studies, and some studies it doesn't seem to work, and so, who knows why that is. I don't know if it's because we just don't understand it fully like we should, or if taking an external amount of it is just not working. Maybe it's not getting in the brain where it needs to be. A lot of possibilities, but it's intriguing, but I think it's too early nobody really knows for sure, so I probably wouldn't waste my money on it. I think, on the other hand, what you could do is play with the light, for instance. This is something I do. It's kind of corny, but I have a little thing called a sunriser. It's a little timer that sets up to my bedside light. And what happens is, let's say I want to get up at 6 a.m., this little thing starts to bring my light up real gradually from about 5:30 and then until it's full brightness at 6 a.m. So it's like the sun rising right next to my bed, and basically I'm sure what it's doing is it's suppressing my melatonin, which then allows me to wake up better. And sure enough, how usually you get up and it's dark and you're groggy and this kind of thing, I kind of jump out of bed. It helps a lot. Where did I get that? I think probably somewhere on the internet.
Didn't wake your wife up?
I'm selling. See, they should pay me commission here. The brand, there's probably other brands. It's nothing fancy. Probably somebody could figure out how to make it, but it's just it has to have a timer on it. It has to have a clock on it, so you can set it for the current time and then what time you want to get up. But it's called the Sunriser. It's RIZR or something like that. Sunriser, RIZR. But incidentally, some people have, we've talked about seasonal affective disorder here before, and so the theory is the days get very, very short in the winters, and you have all this nighttime, and even during the day it doesn't get very bright, and so somehow that affects the mood, and if you think about it, what happens, the kind of depression that people feel in the winter, that seasonal affective, to me looks very much like hibernation. It's like we're meant to be hibernating, but we're not. We're not allowed to because our society says no. So no naps, none of this stuff, right? I think probably what should happen, what we should be doing, is we should be sleeping more in the winter and sleeping less in the summer. And I think that would be a normal thing. We sleep when it gets dark. We wake up when it gets light. Think about it in the old days, caveman days. You didn't do anything after dark because you had to do it by fire. You did everything else so we sort of artificially do something our bodies don't want us to do, and then we end up paying for it, So the way folks deal with that is they have bright light therapy. So the person with seasonal affective disorder, they would sit in front of a bright light for an hour and a half every morning. And the bright light is supposed to mimic the sunlight without the harmful rays. And they just read a book or something in front of it. They don't stare at it. They just read a book in front of it for an hour and a half every morning, and it tends to really treat their depression. It's pretty amazing.
I have a tanning bed.
You know, I've heard people
It
say
helps.
that.
It really does help.
It might. I mean, I don't know why it wouldn't, to be honest with you. Probably the spectrum has to be similar to the sun, or you wouldn't be getting a tan. I don't know details about tanning things. But the problem with that is, I mean, what I'd do is I'd go and I'd cover my skin because it's not so good for the skin, you know. So, but anyway, any other questions? I don't mean to go all night here. Thanks for coming, guys. Great questions.
Thank you.